All right, well, welcome everybody to Modifying End-of-Life Planning to Appeal to Underserved Communities. We are super excited that you all have joined us today. I am Autumn. I'm representing Arizona State University College of Health Solutions, and this is a partnership between ASU and the HPNA Phoenix chapter. And like I said, today's webinar will be recorded. I am Autumn. I am currently ASU Project ECHO's coordinator. So if you came from the ECHO world and not the HPNA world, you know all about me. For those who don't know about Project ECHO, we are a continuing education program. We are committed to spreading information to underserved communities in rural areas. So it is free CEUs. We have lots of programs and would love to have you join us there. I'm also a new nursing student getting my master's entry into nursing, and I'm a new student member of the HPNA Phoenix chapter. So any questions in the chat box, I will keep an eye out on those, try and answer them as best as I can, and then I'll bring them up at the end. So the HPNA Phoenix chapter, we'd love it if you would join us if you are not already a member. It is not strictly for nurses, it is for everybody. And I'm also putting some upcoming events into the chat that the HPNA Phoenix chapter has coming up. The last one on the chat comment is our part 2 to this series, this modifying end-of-life planning conversations is going to be a 3-part series. So this is just the first one. We've got our second session in June and would love it if you'd join us there as well. And then we will be hosting a 3rd session in the fall after everybody takes a nice summer break. I have the honor of introducing Deb Rashad and Althea Halchuk, who are our presenters today. Deb is the HPNA Phoenix Program Chair. She is a bachelor's registered nurse and end-of-life doula. And Althea has so many credentials, I had to limit it. She is the owner, founder of Ending Well Patient Advocacy. She has her health law degree. I have messed this up a few times, so I'm just going to keep it at that. She is a professional mediator, certified thanatologist, a board certified patient advocate, and so many more things. So she is so wise, got so much information. And with all of that, I'm going to kick it off to our wonderful speakers.
All right. Again, thanks and welcome, everyone. We're glad that you could be here today. I remembered that in my introduction on the Nursing Network site, I indicated I started the beginning of a story of a patient named Jack, and I promised that I would share the outcomes. What we had in 1988 was essentially what we would call today a patient-centered goal concordant meeting. And we included the team was physical therapy, dietary or the dietitian, the hospital chaplain, and the patient's wife, and a peer from his church who he felt particularly connected to. This gentleman was seriously ill. He had been in the hospital for months, not for weeks. He had been there for months. And we were growing, as the team working with him, we were growing desperate, afraid that he would not survive his hospital stay. So we had this put together the team, and it was very informal. There was not a lot of structure to it, but what I am proud of is we really listened to this patient's goal. And his number one primary goal was to get well enough to be discharged home so he could then take his grandson fishing. And I'm happy to report we held the meetings every 2 weeks because of his slow progress. We didn't want to demotivate him by having the meetings too soon. And I'm happy to say that before we could hold his 3rd meeting, he was discharged home. Granted, he was weak, he was frail, but he went home. The best outcome is one that I was able to participate in several months later. I was working on the unit, paged stat to the nurse's station. I thought, oh my gosh, I've either done something wrong or somebody's in trouble. Got up there, and here was a vibrant, moving, engaging Jack. And he said, I have got to tell you, I've got something I have to show you. And he proudly pulled out of his pocket a picture of him fishing with his grandson. That snagged me. That told me that the best thing we can do is listen to our patients and to be with our patients. That began a search for me where I searched high and low for a team where I could offer or be a part of that kind of care. And I'm very happy and proud to say it took a while. It took a long while, but in 2017, when I started as a hospice nurse, I found that team. So with that saying, let's take a look at our learning objectives today. Our objectives are that you as a participant will re-explore racial and ethnic disparities that persist, even though we have been talking about engaging with patients around advanced care directives for close to 30 years now. We know that some disparities have grown even more in recent years. We're hoping that you will better understand how various underserved groups are viewing and thinking about advanced care planning, and how some of the language and the terms that we use, such as end-of-life conversations, that we value your time. We want to give you peace of mind that actually, that's the great part about this qualitative research. They did observations, interviews, focus groups, and surveys to really try to learn what is it that the people we're trying to serve, what is really important to them, and what might really prove to be a benefit to them in both serious illness and end of life. We're also hoping that you as a participant will discover new or different ways to hold positive conversation with those folks about the benefits of advanced care planning, the benefits that they can relate to. And we certainly want to include both palliative and hospice care in these objectives.
Hi, everybody. I'm Althea, and now it's my turn. Welcome and thank you for coming. This is a lot of this is very dry, so we're going to try to make it interesting and informative as best we can. And if we're talking about advanced care planning, we need to know how it started. And it started with the Patient Self-Determination Act, which was a federal law passed by Congress in 1990, and it gives competent, capacitated adults over the age of 18 the right to create an advance directive, including the right to accept or reject medical treatment, even if it's life-saving, and the right to choose a surrogate, proxy, medical power of attorney, whatever term your state uses, to speak for them when they can't speak for themselves. Congress is currently revamping the law to give people more power over their healthcare decisions. And so they codified patient rights and advanced care planning. And in this law, there's a lot of things that hospitals and providers are supposed to be doing about patient communication, helping with advanced care planning. The one person who is very responsible for having this act passed is Nancy Cruzan. Her role in advanced care planning, she was 25 years old. She was on a road in January 1983. She was in a car accident. She flipped over, landed in a ditch face down, and they were able to revive her. She could swallow, but she was in a persistent vegetative state, and she had a feeding tube. She had this tube for 8 years. She had no advance directive. She hadn't appointed anybody as her surrogate. So her parents kept trying to take her off life support, and they finally appealed to the Supreme Court. And in 1989, the Supreme Court, in their ruling in 1990, said no. You need clear and convincing evidence about a person's wishes, and they didn't have that with Nancy. So what happened was they bumped it back down to the Missouri State Court. And what happened there is that Nancy's friends came forward, her work friends, and said, you know, we had a conversation about this with Nancy, and we talked about, would you want this to, if this happened to you, I don't know what they were referring to. It could have been Karen Ann Quinlan, because all of that happened, you know, like 10 years before that. And she said, no, I'd never want to be hooked up to machines. So the court accepted that testimony, and they allowed her parents to take her off life support. And 12 days later, she died in December. And you can see this is her memorial. She was born in 1957. She departed. That's how her parents put it. Like, for them, she died in 1983. But finally, she's at peace on December 26, 1990. One thing about this is that it shows how important conversations are, because the court considered those conversations with her, nothing was written, clear and convincing evidence. That's what she wanted. So just remember that when, you know, we talk about conversations in advanced planning, that's just as important as what's written. So after 30 years of this law and people being allowed to make advanced directives, the last couple of decades, we've been stuck. I mean, for 30 years, probably 20 or maybe 15 of those years, it was 20%. Then it kind of creeped up to 25. With COVID, it went up to 30. But for the last couple of decades, really, it's been at 30. It moved up in degrees. So what are we doing wrong? Is it messaging? Why aren't people stepping up to make an advance directive? Massachusetts, their serious illness care, did a research study, and it was a 5-year project focusing on the experiences of Black and Latinx, low income, people with serious illnesses and disabilities and their caregivers. They sought to understand the needs and challenges in navigating the healthcare system and their experiences engaging clinicians in conversations about medical decisions and choices. They studied which actions should be prioritized to improve communication by listening and communication long before serious illness takes place. You need to have these conversations way before you get sick. The first thing we need to do is define serious illness. And serious illness, here's a list of typical conditions that fall under serious illness, but it's certainly not complete because there's nuances in this. Neurological diseases, that can include ALS and MS. So those kinds of serious illnesses that aren't going to kill you tomorrow, but it's a health condition that is a high risk of mortality, and it either negatively impacts a person's daily function, their everyday activities, or their quality of life, or puts strains on their caregivers. And 20% of the participants that responded in the survey claimed that they had serious illness. Now, these are the typical reasons for the general population not engaging in advanced care planning. And I do workshops on advanced planning, and these are some of the reasons / excuses you hear why people haven't done it. The first one, I'm too young to talk about death. The 3 landmark end-of-life cases involve women in their 20s. Karen Ann Quinlan, Terry Schiavo, and Nancy Cruzan. They were like all in their mid-20s. And they were kept alive way longer. I think Schiavo, it was like 12 years. She was kept alive, and the parents and the husband are still fighting about it. Too busy, no time. If you don't make time, the decisions are taken out of your hands, and you might get care you don't want and it's decided by somebody you don't want it to be decided by. I'll die prematurely if I do my advance directive. Well, superstitions don't cause death. I've never heard of a case where somebody died after doing their advance directive. God will take care of me. If you believe that, that's great, but maybe is it the care you are going to want? These young women were believers, to my knowledge, and yet they were kept on life support for way longer than needed, really. They were all in, never mind. That's another lecture. The forms are too complicated. Not really, but you really have to think about them. I just did a webinar with 5 Wishes, the group that makes 5 Wishes, and they went through it all. It was like a 45-minute webinar, and they talked about each wish and what you have to do. So really, the forms aren't complicated, but they're personal, and you need to make decisions and write them down so your family and your doctors know what you want. My family knows what to do. Well, I've been a mediator for 20 years, and most disputes are in an ICU at the bedside of a dying loved one because families don't know what to do. They don't know what to do. They argue with each other the right thing to do. So really, if you think your family knows what to do, many families do, but most families don't. In the research, these are the slides from the research, and there's a lot of the same ones I just mentioned, but the biggest reason, close to half of the people surveyed said they just hadn't thought about it. Nobody put the thought in their head. You know, like, if people don't talk about it, then they're not going to think about it. That's why we have Healthcare Decisions Day, April 16th, always the day after tax day, so that we can bring more awareness to people in the country about advanced planning. We had 3 key insights. Well, I'm sorry, we had key insights. These are questions that were asked of the people being surveyed, like, what do you think about quality of life? And that term resonated the most with people. They care about their quality of life. And having the control and power over decisions impacting their life, they felt, was a way to attain the quality of life that they wanted. What matters to them, that was also, people also reacted positively when they talked about what matters in their life. Is it their family? Is it their job? Is it where they live? Is it traveling? What matters most is important to everybody, not just the people in this survey. Having a good day, they shifted away from having a good day, like talking about end of life options, DNRs. They don't want to talk about that. Having a good day to them is personal. So they kind of shifted away from end of life options. Family and loved ones was kind of like a loaded topic for many people. Some people, you know, they had a family, so they really didn't need an advance directive. Other people felt excluded from planning because they didn't have a family. And so that was kind of a wake up. Not everybody has the same kind of family. Not everybody has loved ones. And so you need to appeal to people where they are. And if these people don't have loved ones, we need to change the message about that.
So let's get started by looking back to people's experiences, and then let's try moving forward to provide better communication and care. So we know that when we're working in palliative care or around serious illness care, a key part of that does circle around communication. So with this in mind, they asked, what makes good communication about serious illness? And what we found is people who are willing to speak up and share what matters most to them. And you know what? In my experience, when we ask the people we're serving that question, they will respond to it. And it's an opportunity for us to teach empowerment for them to advocate for themselves. They also require clinicians, people like all of us in this meeting, who will stop to take the time to ask and then to listen to what the person sitting across the chair, across the table, is actually saying to them. Also, we know that being listened to in the past is going to influence how much that patient or family member is willing to speak up when it truly matters to them. So again, a critical way to improve not only serious illness care, but also end-of-life care is to address listening and communication long before a serious illness diagnosis. So that's one of the reasons I'm excited to see some of our fellow acute care people here. It is appropriate for all of us to start these conversations. So some sample, that's okay, we'll go on. So open-ended questions help us better understand the patient's experience and the patient's perspective. So they focused on open-ended questions, and they wanted to hear about what were your good experiences as well as your bad experiences. And actually, across every group that was polled and surveyed, people had many positive healthcare experiences, and we sometimes lose sight of that. Why is that? We know from serving patients who are our customers, we typically hear about the negative things more than the positive. So let's remember there are some positive things going on out there, but it's also important for us to strive to better understand what are those negative experiences. So this survey found, or surveys found, that most negative experiences were due to a mix of discrimination, a lack of empathy, poor communication and listening skills. And we know we've all dealt with this, frustration and anxiety trying to deal with our current healthcare system. The insurance cost, access to doctors, having to wait prolonged times to get an appointment, as well as receive services once we're there for the appointment. We heard about misdiagnosis, a feeling that folks were sometimes being pressured to accept or engage in treatments that they didn't really want or they didn't really think was necessary, and felt like they weren't going to contribute to their health and well-being. So it's important for us to know, while there were actually many positive experiences, there was a strong perception that negative healthcare experiences were widespread, and it was felt that positive experiences more likely were the luck of the draw. We saw that age and illness, along with race and income, leads the list of perceived reasons that these people feel that they're receiving unfair treatment by health professionals. But it is important to note there are other reasons as well. Whether I have insurance, whether I'm male or female, or what my gender identity is. Disability, it was interesting that those with disabilities oftentimes matched the results we were seeing with those who were struggling with and trying to deal with serious illness. Language difficulties. We are a nation of diversity, and language differences are here to stay with us. Sexual orientation, among others. So as I mentioned a minute ago, both those folks with serious illness and with disability are about twice as likely to report having left a healthcare visit, whether it was a treatment, an appointment. They felt unsure about the visit. They felt unsure about the outcomes, what really happened, or what the next steps were going to be. 87% of these adults truly think that clinicians should know their priorities and what matters to them in order to provide high quality care. So we know that this is important to the people that we're serving, no matter where they fall in gender, in economic status, all of those. This is important to them. The study found that conversations with loved ones and around documentation were largely flat. And we're going to choose to focus on the US because that more broadly represents our group here today. As far as having a serious conversation with the spouse, parents, significant other about wishes for their medical care, we only saw 1% move between 2017 and 2021. As far as having a serious conversation about who will make the decisions about my medical care, we actually saw a drop from 62% to 54%. And this is interesting because 2021 was when? It was right in the midst of the COVID experience that was impacting all of us. Documented healthcare proxy and written names on a healthcare decision maker. Again, we saw a decrease in 2017 to 21 from 41% to 33%. And again, we're pretty flat on people actually having written documentation. So this kind of gives us an update, even with the passage of COVID. We find that people with serious illnesses are more likely to have at least had a conversation about their serious illness. But when we're looking at the whole composite, the rates are still very low. 54% to 63% said that they had conversations, but then, and about the same amount with their spouse and parents. But look at the difference when we shift the focus to having a serious conversation with a doctor or a nurse, a member of the care team, about your wishes for medical care. So this is an opportunity for us to make improvements in this sector. So would you want to talk to a doctor or nurse about your wishes? Around half of the people said yes. And then we see, have you had a serious conversation about who will make? We made some strides. We went from 20 to 34%, but is a third of the population where we want to be. So we saw it was similar in documented healthcare proxy and documented wishes for medical care. And would you agree? These are all lower than we'd like to see. So let's take a look at some of the ways we can approach this and impact this. So one of the things we found in the qualitative research is the testing revealed and hopefully gave us a window of insight into what people's concerns are, what their expectations and what their perceptions are of the care that they're receiving. And a lot of these statements, again, were resonant with folks by saying, we'll figure this out together. We're emphasizing we are a team and we're working on this together. Let's make a plan for your care in case you can't speak for yourself one day. This is speaking to those patients who said, you know, I want to be able to speak up for myself. I want to know that I can have some control over my care. I know that healthcare treatments can be expensive, can be a softer entree into conversations that are necessary about what their concerns are about affording their treatment. And then remembering treatments only work if they work for you. Again, how many of us here have a patient-centered care focus? This is a patient-centered care focus by asking these or making these kinds of statements. Then also positive was hearing from their provider, I'm keeping up with the latest research, treatments, and ideas. But again, let's remember, it's so important how we communicate around that I'm keeping up with research, treatment, and ideas. It has to be seen as genuine and as sincere for people to really believe that. Someone, me, myself, a member of my care team, one of my coworkers, we will always call you back. Again, we have to show the integrity and show them that we do follow up on what we say. Your time matters to me was a mixed one because it sounded good to people and they wanted to believe that, but yet they indicated, I don't know that I really believe that. I still have to wait and wait and wait to get in to see a doctor. I still am often sitting hours in a waiting room. So how does that tell me that my time is really valued? So we need to be aware of that and attentive to that. And again, a lot of patients are concerned if they talk about the challenges with their healthcare costs, that will assume that they can't afford treatments, or that perhaps they won't get the treatment that they really need. I get that sometimes life and other things can get in the way of your ability to get care. Sounds a lot better than, why haven't you shown up for your last 2 appointments with me? Let's talk about what is getting in the way of your ability to get here for appointments. I treat all my patients equally and recommend the kind of care I would suggest for family or close friends. As an example, my husband, that's one of the first questions he wants to ask. So here are some concerns about having advanced care planning conversations with doctors. 1, they may not have a regular doctor, or they may not have a doctor that they trust. There's also a real issue of a mismatch between outpatient care and inpatient care. Most of the people in hospitals today, their physician is a hospitalist, and people have concerns about how much of what happens in the hospital is really shared with my medical doctor, the doctor who's supervising my day-to-day care. And their current doctor more than likely may not be the one who's going to treat their serious illness. They trust their family, that they haven't thought about it, or they think they're healthy, so I don't need to make this an issue. People are still saying their doctors have not brought it up, even though Medicare has added, hopefully, some financial incentive to encourage physicians to talk about this. This tends to lead us to believe that some folks are not feeling like they can have that kind of conversation, and some folks do want to talk to their doctors about this. And another concern is, have they had an advance directive, and how confident are they really feeling in their choices? And we'll talk about this one a little bit more later.
These are every group can benefit from speaking up and having a say in their care. And there's various ways that it can benefit each group. So Blacks, Hispanics, Asians, they can advocate for disparities in healthcare and really look for equitable and high quality care. People with disabilities, speaking up ensures that their providers meet their unique needs and accommodations. People with serious illnesses can advocate for their preferences and priorities and can receive the care that aligns with their values and goals, so it'll improve their overall quality of life. Caregivers are so important. They play a crucial role in advocating for their loved ones' needs and preferences. Speaking up can help ensure their loved ones receive appropriate, person-centered care. And individuals age 65 and above, speaking up can help them receive the care that's tailored to their specific needs and preferences. It's important that all individuals feel empowered to speak up and actively participate in their healthcare decisions to ensure their care is personalized, respectful, and aligned with their values and goals.
So when asked about what are the things that you worry about with a serious illness, this research found that white adults are most worried about getting inferior care due to something about their identity, as well as Hispanic adults, but not as strongly. We found, on the other hand, Black respondents worry most about healthcare, either by surrogates or by themselves, while we found that Asian adults report fewer worries. And I'm not going to go over each category. You will have those in the handouts that will be provided for you. But again, we notice there are certain similarities in groups as well as significant differences. Look at the spread between, if I can't speak for myself, my family and friends won't make the best or right decisions. We had only 12% of our Asian and non-Hispanic respondents report this versus white individuals, non-Hispanic, were concerned about this 36% of the time. Black individuals were concerned 32% of the time. So this is helpful to look at to understand what is your population group, who is it that you either are serving or you strive to serve in a better capacity. How can we take a look at these worries and how can we better position our care to meet these perceived worries? Not getting the best care and concerns about my surrogate making good or best decisions for me topped off the list of worries around serious illness. And we could see that these are major concerns if you look at the folks who are very worried and somewhat worried that there are some significant concerns about not getting the best care due to my race, my ethnicity, my age, my income. And if I can't speak for myself, my family and friends won't make the best or right decisions. And interestingly enough, we found this concern was often highest in the group that already had their advanced care plan written and completed. So I think this emphasizes the opportunity for communication. And again, why we encourage folks to consider revisiting and relooking because life changes, needs change, goals change on at least an annual basis. And this slide is showing what I mentioned a while ago, that the most worried adults are the ones who have actually completed all advanced care actions. So this is again critical to the part of how communication factors in. When we are able to build a relationship of trust and respect with our patients, they're more likely to share with us what their concerns and their worries are. So here's some additional worry insights that was found from conversation statement testing. People are concerned about medical costs. They worry that if I disclose or I share concern about how am I going to afford this medical care, that might actually affect their care and the treatment options that they are offered. They want to be reassured that if they share those concerns, that the team, the doctor and the team will not withhold choices that will help them. Expertise. It's a given that people expect and they want expert doctors, team members that have special expertise. And this is a balancing act. On one, they want to be assured of this expertise, but on the other hand, some groups viewed this as expressions of arrogance or suggesting that there's a power imbalance, that, I'm the doctor and I know the best choices for you. So we want to encourage perhaps people to consider more of a guiding approach than a direct authoritarian type of approach. Time, and I mentioned this earlier, so I won't spend much time, but again, on the one hand, we hear that our time is valuable. On the other hand, this is what I'm experiencing as a patient of the healthcare system.
Who doesn't love a Venn diagram? Everybody wants to be treated like a human being and not a number. So the little circles on the left are factors that contribute to positive healthcare experiences and trust building. Empathy and kindness. Doctors and staff who show empathy and small acts of kindness can put patients in a positive experience. And that involved understanding and acknowledging their emotions and their experiences. A friendly demeanor or accompanying gesture like a hand on a shoulder can improve the patient's perception of their care. Efficiency, and we've talked about this, about the timely appointments, minimal waiting, streamlined processing. They all contribute to a positive experience. Patients appreciate it. Everybody appreciates it when their time is valued and their healthcare needs are addressed promptly. Attentive listening. Providers who actively listen to their patients' concerns and needs create a positive experience. Recognizing values, preferences, personal circumstances help tailor healthcare decisions and treatments to their specific needs. Patients feel heard and understood when their healthcare team takes the time to listen attentively. My husband has a PCP that's a holistic MD. So he is such an attentive listener. I had to go with him for a visit, and I'm so impressed with him because he does everything on the left side. And it's very difficult to find a doctor that does all of those. Now, the factors on the right side contribute to negative experiences, and trust is eroded. Discrimination and racism. Individuals that are treated unfairly or differently based on their race, ethnicity, or other personal characteristics. And it's not just historical, like the Tuskegee syphilis experiments. I mean, that was horrible and bad enough, but this is discrimination and racism now. And it happens every day. Lack of empathy and poor communication. Lack of understanding or concern for a patient's emotions or feelings and overall well-being. The doctor doesn't listen or the staff doesn't listen, discounting their symptoms, saying, oh no, you must be wrong, or no, that isn't the cause, whatever, not seeming to care. This can lead to misunderstandings, confusion, and frustration on the part of the patient and a poor experience. Limited access to quality care. Access to high quality care remains an issue for many groups, and that includes because of high insurance, high medical costs, long wait times, and difficulty accessing care. Misdiagnosis can lead to delayed or inappropriate treatments, unnecessary procedure, and prolonged suffering. Staff often does not consider the impact of healthcare decisions on a patient's quality of life. Negative healthcare experience. In our resources, we included an article, 3 best practices for showing empathy and compassion in healthcare. And there's a link to a really nice Deloitte study from 2021 on healthcare trust, how healthcare organizations can build trust with their patients. Summary and reflection about what people want. People want, and this isn't just in the survey, this is in general. People want mutual respect, collaboration, non-judgment, empathetic care from their clinicians. Across all the different testing exercises, people value this kind of attitude and theme and language the most. It rankles people to sell what they perceive to be things that meet their baseline expectations, like courtesy and human decency. These shouldn't be positioned or marketed as something novel or new or nice to have. This is baseline. For many, these concepts touched a nerve. There were stories of empowerment across all racial and ethnic groups. People got weary of less than satisfactory experiences with their healthcare providers, and they changed doctors or switched to a new practice. Sometimes you like the doctor, but you don't like the staff that you have to deal with. And many people did this multiple times. They just kept changing until they found a doctor they liked, one that met or exceeded their expectations. The power of word of mouth. If you're new and you need a dentist, what do? You ask somebody, who do you use? They found that patients were inspired by others in online communities by giving a referral to a good doctor. People are willing to make trade-offs to get high quality care. They're willing to sacrifice some of their time, such as scheduling with specialists several months out, waiting for a doctor who's running late. These are trade-offs. Another one is to have a doctor with the same ethnicity as them. And that's important to a lot of people, especially in this study, because that's who we talk to. That's a trade-off for them. If they have to wait 3 months for a doctor with the same ethnic background, they'll wait. Believability, Deb talked about that before. You know, it's all in theory, these concepts sound great, but given the experience of the people in the survey, they said doctors barely made time to discuss with the patient what was going on at the moment, never mind talking about advanced care planning. Cost factors into everything. Regardless of how it was framed, people quickly asked about the cost and whether their insurance would cover it. Many policies, you have to pay 20% of what isn't covered. So that can be a really hard amount of money for many, many people. And what matters most is high quality care from a doctor who treats them like a human being, shows empathy, truly listens, advocates for them, treats the whole patient, involves them in decision making, and ultimately makes them feel better. They don't want to be treated like a number, they want to be treated like a person. This call to action these were things they said to people, and they kind of rated them on how people reacted. So You Can Speak Up was received as the most impactful action across all the segments. It was especially effective when it was presented in the form of a clinician communication. You can speak up about your care. You don't have to wait for me to tell you what to do. You can do it. It's empowering people to advocate for themselves. You can make a plan for your health care in case you can't speak for yourself. In other words, talk to a trusted person about being your proxy surrogate, so who can make these medical decisions for you when you can't. And you share with that person what matters most and what your good days look like. We talked about good days and what that looks like to an individual. And I do presentations on just choosing the right surrogate, an effective surrogate, somebody that's going to speak up for you and carry through with your wishes. Because if you're incapacitated, that's who's going to have to follow through. You can put your end of life affairs in order. Some had end of life documents already, but others didn't want to talk about it if they were healthy. The perception of getting end of life plans in order was generally lower in the terms of impact, relatively higher though in certain groups, such as people over 65. You know, the clock is ticking. You're 65 years old, you better start getting your advanced plans in order. You may have had a health crisis, and now is the time to put it down on paper. People with serious illness were also impacted by these statements about getting your affairs in order. And you can pick the right doctor. It was seen as the most impactful for people with disabilities and caregivers, even though it was considered more difficult and less believable than You Can Speak Up. The action that was the most impactful was You Can Speak Up and have a say in your care. And it was perceived to have the greatest positive impact across all segments. The key takeaways from this study, and by the way, the study is in the resources, it's 73 pages long. And Deb and I went through and kind of winnowed out the ones that we thought were interesting, and we kind of focused on certain groups, but it's 73 pages and it's really an interesting study. The key takeaways: advanced care planning rates have remained largely unchanged in recent years with race, ethnicity, and income disparities. 30% in 30 years. They're going to embroider that on a pillow. Good communication about serious illness involves people willing to speak up, there it is again, and share what matters most, as well as clinicians who take the time to ask questions and listen to the patient. My husband's PCP, I'm telling you, he is the benchmark. Quality care can only be provided when clinicians know what their patients' priorities are and what's important to them. Isn't that the truth? Speaking up about what matters is seen as the most impactful thing that people can do. Addressing listening and communication issues long before serious illness diagnosis is critical to improving serious illness care. You got to do this before you get sick. Past people's experiences of being listened to will influence how much they're willing to speak up when it truly matters in a serious illness. So if people haven't listened to you, I mean, you're going to say to yourself, what's the point of banging my head against the wall? People want mutual respect, collaboration, partnership, dignity, humanity, empathy, non-judgment from their healthcare providers. They also don't want the doctor making decisions for them. That's kind of a thing with people. Let me make my own choice. Give me the options and let me make my own choices. Negative healthcare experience erodes trust, hinders speaking up, particularly for people with serious illness, disabilities, lower incomes, and Black and Hispanic individuals. And traditional advanced care planning and end-of-life planning actions are seen as relatively low value compared to having the right doctor and speaking up about what matters. You can have all the forms in the world, but if your doctor isn't on the same page as you about what you want, what matters to you, then what use is the planning? That's what a lot of people in this survey thought. Actionable recommendations to improve advanced care engagement and patient-provider communication and quality of care. So these are recommendations that they came out with. Encourage patients to speak up and have a say in their care. I mean, speaking up, I mean, how many times have I said it? Incorporate patients' ideas and questions into the decision-making process. Informed consent, that's what it's all about. That's what the Patient Self-Determination Act was all about. Giving patients informed consent to make their healthcare decisions. Provide education, information, and support for patients about advanced care planning. People love papers. They love to see how to do things. I think that's why 5 Wishes is so popular, because it spells everything out in a nice little booklet. Treat all patients equally with empathy, address barriers to accessing care. Address racial and ethnic disparities in advanced care planning engagement. You need to talk about this stuff. And if somebody only speaks Spanish, are you doing advanced care planning in English? I mean, that just seems like a basic thing. You know, you have to meet people where they are in the language that they speak. Address concerns and errors promptly. Don't let it fester. And consider the financial aspect of healthcare. Healthcare is so expensive, and medications. I needed a medication. I have a bad knee, and I asked my ortho guy for a medication. It was $1,000 a month, and I said to myself, didn't he know how much this costs? I'm not using that. $12,000 a year for some lotion to put on my knee. And so I think medical people need to factor that in when they're talking to their patients. How much is it going to cost my patient? A lot of times they don't even know. You find out when you go to CVS. That's when you find out. Here's the resources. The first one is the Coalition for Serious Illness. It's great. I also Googled this, and every year from 2016, they kind of did a report, and those are kind of interesting too, the people that they got in their survey. The Deloitte Healthcare Trust study, also excellent. 3 best practices for showing empathy and compassion in healthcare. That was a blog. Motivational interviewing, a communication best practice was written by Deb, peer reviewed, excellent.
And I would like to speak up for just a moment about the reason for putting motivational interviewing. Call it MI. That's a more user-friendly term for those of us in palliative and hospice care. Have you noticed a theme here? We might be saying, you know, a lot of these things you're talking about are in the enormous, huge healthcare system that I cannot impact. But what we want to remind ourselves here is how much power we have in communicating with our patients, connecting with our patients, making them feel valued and respected in our relationship. Motivational interviewing has over 200 meta-analysis, and one of the things that people say most often, yes, it can be used for long-term behavioral health change, but long before that happens, when people start using the OARS concept, for instance, if this is a new communication skill for you, consider the article as just kind of an introductory prep. If you've been trained in motivational interview, consider it a review for you. Then I encourage everyone to get more intensive certification, and that are more intensive training. That would be under number 6. But again, even when people are very first exposed to the communication technique of motivational interviewing, they report back things such as, I've never felt so listened to. I've never felt that my opinion was so valued. So it helps us to quickly, as busy clinicians, be able to establish that relationship of trust with the patients that we're serving. We also—
Deb, we're running out of time, and I really want to talk about the messaging toolkit.
Right, and that's what's coming up next. So I'll let Althea tell you about that, because we certainly want to get that in your hands.
Yes, it kind of goes along with the research study, and the first thing you need to know about it is that it isn't copyrighted. You can use anything in there to use to do advanced care planning with people. And one of the things they learned in making this toolkit was they had been making assumptions. They said, don't make assumptions. They thought everybody knew what serious illness was like, but not everybody does. So you have to tailor your advanced planning to, again, meet people where they are. Another big thing with this group is that assumption 2 was most people would accept death if they learned more about how great hospice is. Well, guess what? 10% of the lay public isn't interested in death positive talk. They don't want to learn about hospice. They don't want to hear about hospice until they need to. So that's kind of a big thing. I think for me, you know, like I'm in the death positive movement. I assumed everybody was, but they're not. They really, you know, like if you talk to your friends about death, you know, they run the other way. So, and they assumed people had positive experiences in their serious illness. But what they found out from stories from people was that serious illness care means being in a dingy hospital conference room, hearing from a doctor they never met that their parent, sibling, friend, pick one, was at a point where they decided to give up and have them taken off machines. So these are the stories that people heard when they were doing this toolkit. So when you introduce advanced care planning to the public, talk about what every person wants when they're in a tough place because of serious illness, sense of control, reasonable choices, and support to get through it. That's what everybody wants. The toolkit will help you speak that language. And it's only, I think, about maybe 15 pages, if that. It's really great. You have to go on this website and download it, but you'll learn a lot from it, and your patients will be grateful.
And this is what we'll be using in our second session. We will give an example of how to use this toolkit. So I encourage you in the interim to be thinking about more deeply about what your population group is, who it is that you're trying to reach out to. We found that serious illness messaging was very positively received when we talk about it being another layer of support for both the patient and the family. So we encourage you to think about that, think about how you communicate with your patients. And we want you to know, we know that we're just about up on time, that Althea and I are happy to remain online for a few minutes if we didn't get an opportunity to answer a question. You can either put it in the chat room, or you can just simply raise your hand and we'll be glad to answer as best we can. Thank you for spending your time with us today.